afternoon, everyone, and welcome to today's Public Health Ontario's Rounds presentation titled PHO Rounds, Artificial Intelligence and Public Health, The Future is Now. My name is Laurie McKinnon. I'm the Manager of Analytic Services at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. And if at any point during this session you experience technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I have no conflicts of interest. It is now my pleasure to introduce the speakers for today's presentation, Dr. Andrew Pinto and Sharon Birdie. Dr. Andrew Pinto, a public health and preventive medicine specialist, is the founder and director of Upstream Lab. He holds the CIHR Applied Public Health Chair in Upstream Prevention and is a family physician at St. Michael's Hospital at Unity Health in Toronto. Additionally, he's an associate professor at the University of Toronto and serves as director of the University of Toronto Practice-Based Research Network, Utopian, leads clinical research for Ontario's Poplar Network, and founded the Canadian Primary Care Trials Network. Sharon Birdie is a research coordinator at the Upstream Lab with interests in responsible AI and public health. So with that, I'll pass it on to our speakers.
Thank you so much, and welcome to everybody today. It's a great privilege to present, and we're really excited to share some of the work that we've done and also engage with everyone here in a discussion. I just want to note, I'm fortunate not to receive any funding from for-profit or commercial entities. And just for transparency, where we receive funding from, I do serve as an unpaid advisor to a colleague's company, PHO. And these are for Sharon as well. And we just want to start by noting the land in which we're meeting and where the Upstream Lab and where PHO's head office is in Toronto, which is the traditional land of the Huron-Wendat, Seneca, and most recently the Mississaugas of the Credit. Toronto is covered by Treaty 13. And really important to this work is always keeping in mind the calls to action specific to the health sector and to public health that are in the Truth and Reconciliation Commission report. And also when doing a land acknowledgement, I really want to give something very tangible for people to consider. So this really fantastic textbook on Indigenous data sovereignty and policy is really helpful, and it's also completely open access. And there's a fantastic chapter about Canada specifically in this book as well. So the Upstream Lab, which is where we're both based, does work in a variety of different areas. It's now about 8 years old, and the team has grown to include other scientists, and we now have a team of almost 40 staff and about a dozen graduate students and postdoctoral fellows. We do work in a set of related areas, from integrating health and social care and tackling social determinants, data science, which this is most relevant to, population health management, including things like democratic engagement, as well as supporting high quality trials. And one of the big projects that we're leading is this national adaptive platform trial of treatments for COVID, with very strong support from the Public Health Agency of Canada and funding from CIHR and Health Canada. And so I mention it in part just to make sure that you think about it if you or others test positive for COVID, that we don't yet know what really treatments work and what helps reduce long COVID. And we're very excited to be doing this. So for today's session, our objectives are to look at some common terminology used in AI and think about how AI could be applied within public health practice and research, to really look at some of the strengths and limitations of machine learning, including some of the important concerns that exist, and also talk about how data and these new technologies could contribute to a learning public health system, and maybe some lessons from newer networks that are starting to form that really engage with data and bring it into practice, and how this could actually influence future public health practice. So we're going to cover a fair bit of ground today in the next 40 minutes or so, from talking about AI and methods to applications of ML or machine learning in public health that we found through doing 3 very rigorous systematic reviews. We have created some guidelines for applying AI and ML in public health, and then we'll end on that note about what would a learning public health system look like and what would be the role of data science in that. So with that, I'm going to turn it over to Sharon to take on this next part.
Thanks, Andrew. So AI, what really is it? I think it's important to understand that under the umbrella of AI, there are a few branches that make things rather interesting. 2 of the most common players being natural language processing, which is used to better understand human language and its interplays with technology, and machine learning to teach machines how to learn independently. And there's some neat facets like computer vision and logic programming as well. So AI is definitely become entrenched in our daily lives, from being used in education to work to our daily activities, oftentimes for the optimization and the efficiency of tasks. This slide right here is just the visualization showing the big expectations that people have for ML in the workforce, with its impact on healthcare being predicted to be rather large within the next 5 years or so. In our Canadian healthcare sector specifically, there's definitely been an uptick of interest by organizations such as the Royal College and the Canadian Medical Association. Here's just a quote by Eric Topol. He's a physician and researcher in the US, and he has a rather optimistic view of the role of AI in helping healthcare. And this quote really speaks to that of improving the lives of patients via using AI for decision-making and stewardship of resources. Another huge proponent of using deep learning on the healthcare system is David Naylor, a former president of U of T, who spoke to the promise of machine learning and informing processes of discovery and research, and how that knowledge could then be applied to patient-centric care and the empowerment of staff and patients. So as you can see from this figure, machine learning is progressing rapidly from where it was not so long ago with the gathering of descriptive analytics to now more actionable prescriptive analytics, with emphasis on informing next steps rather than just giving insight into what happened. And I'm just going to pass it over to Andrew.
So I want to just share a few examples of work we've been doing and to maybe stimulate some ideas about where things could go next. One of the things was we actually started by first really engaging in a national dialogue with patients, with providers, with policymakers around what should be priorities for AI, in this case, in primary care. And it was a really useful method to help identify these were 5 key priorities. The first, like addressing things that don't really need physician-patient contact, a lot of the administrative burden, helping with allocation of time across a team, including expert systems that combine kind of the latest evidence with a kind of continual flow of data. You could start to envision what that could look like for public health. Addressing infrastructure issues and trying to not widen the gap across Canada, and also training for people to use these tools. This led us to do a 6-part webinar series with the College of Family Physicians of Canada, which were all recorded and available online as well, that worked through and really helped orient large numbers of people in Canada around this new topic. And some of the projects that we have right now in progress are prediction using primary care electronic medical record data, and moving from a systematic review to actually doing some experiments with data we have, patient engagement and guidelines for AI applications in health, this work around machine learning in population public health, using natural language processing and machine learning to derive social data from charts. So where we don't have rich social data, how could we actually derive it from chart info? And then also working with people on how to best visualize and integrate into clinical workflow this type of new data that comes about. One of the kind of more recent projects has been around automating administrative tasks as well, which is a particularly good use of this technology to make workflow more clear and more reliable as well. One of the things that this has led to as well is starting to form a community of practice of people working in data science and big data and using it to evolve a primary care system. And I'll be coming to maybe a proposal around what this could look like in public health as well. There have, of course, been also concerns about artificial intelligence, which are really important to highlight, that there are issues around how people of different racial background are treated and kind of experience these technologies, how it can also emphasize and reinforce things like surveillance, how it also has changed work. And we're at a point, as the kind of graph showed that Sharon talked about, is it's changing many sectors simultaneously as well. And I want to note that these are concerns that many folks before me have raised. One of the specific kind of pieces is around algorithmic bias, which is where the application of an algorithm actually compounds existing inequities in socioeconomic status, race, ethnic background, and so on, so that adopting this new method can actually greatly amplify and increase those inequities. So a concrete example of this, it could be like in a health setting where a tool is used to decide on who should get extra resources. And that can actually amplify inequities. In a public health setting, it could be making decisions about where to prioritize for, say, vaccine kind of advertising or setting up clinics or even outbreak management. It could actually reinforce and actually increase kind of inequities depending on a lot of different factors. One of the most high-profile examples of this was an investigation by ProPublica in the US, which looked at software used by judges to decide on sentencing, and finding that there was a systematic bias towards longer sentences for Black individuals compared to white, controlling for many other factors. And an important kind of take home is this type of bias that gets integrated into these new systems. It's not only about training data, although that's a big part of it. It's not only solved by training on larger, more representative samples. It relates to also human biases and what sort of questions we pose, who's around the table, and also even how we annotate or label the data as well. Of course, there's even bigger kind of concerns on the horizon as we move from machine learning and variations of it into large language models, which have now been over the last year and a bit kind of in the media a lot. And many will know that some of the leaders like Jeffrey Hinton and others are quite worried that this type of technology is getting ahead of itself and is actually poses a risk to us as a species as well. So just wanted to note that, of course, that's part of the discourse that's happening, and the need to, one, think about the ethical implications of what's happening and the real world effect of this new technology, but also to create parameters so that we don't allow this type of technology to have much more power and control than it should ever have. I'm going to turn it back to Sharon to talk a bit about our work that we did in actually applications of AI in public health and what we learned from a series of reviews.
Yes, so There are obviously a lot of new possibilities for population health and disease prevention, and we studied these through a series of reviews that we conducted at the lab. And a lot of the applications kind of fell into these four categories, which is modeling risk in our populations, modeling disease incidence in our populations, evaluating the effectiveness of interventions proposed, and the rapid processing of vast amounts of data and identifying new relationships in that. And so, as mentioned previously, we conducted 3 scoping reviews to identify machine learning models that were used in specific areas of population health and public health, and to examine really whether and how algorithmic biases were identified. And the 3 reviews had the subtopics of risk factors for chronic disease, non-communicable diseases, and communicable diseases. And in tandem with that, we developed guidelines for the equitable use of machine learning in population health. So here's some of the methodology that we used in each of the 3 reviews. So we really wanted to evaluate studies that used machine learning applications to investigate risk factors for chronic disease, non-communicable diseases, and communicable diseases, respectively, paying close attention to those which had a population level approach rather than focusing on specialized populations or those studies which used real world data rather than general discussions of machine learning. So in our review that evaluated risk factors for chronic diseases, we began with around 17,000 citations and ended up including 20 in our synthesis. As mentioned previously, we included 20 peer-reviewed studies in this review, and a critical blind spot that needed to be addressed, not just in this review, but across all 3, was the recognition and mitigation of algorithmic bias in these models. They're not well reported on. Nonetheless, some findings did validate the exponential growth of machine learning applications in the sector of public health. It was found that COVID-19 accelerated machine learning development and risk prediction and population surveillance, with the studies that we did include for inclusion unevenly focused on smoking, vaping, and alcohol use. And there was limited exploration into the fields of unhealthy eating and psychological stress. In our review on non-communicable diseases, we had a sizable increase in the amount of citations, with about 50,000 to begin with, and 65 included in our final synthesis. In this review, the non-communicable diseases studied included diabetes, cardiovascular diseases, cancers, and chronic respiratory diseases. It was found that supervised learning was the most common algorithm by far. So these are the algorithms that are trained on labeled data sets, where they learn to make predictions or decisions based on input data and corresponding correct answers. The most popular machine learning application was disease modeling. Interestingly enough, though, there was a discrepancy between machine learning application frequency between high and low middle income countries, with most of the studies being conducted in high income countries. And again, there was a major lack of discussion around algorithmic bias within these papers. For our third and final review, we had around 45,000 citations and included around 300 in our final synthesis. These studies focused on COVID-19 specifically, diarrheal diseases, hepatitis, HIV, AIDS, malaria, measles, and tuberculosis. An overwhelming majority of studies that were analyzed in this review were those pertaining to COVID-19. And again, the most popular application was disease modeling using supervised learning approaches. And again, following suit with the 2 other reviews, only 5% of the almost 300 studies included for synthesis implemented bias mitigation strategies. As mentioned previously, in tandem with these reviews, we brought together a team of scientists and academics together and used the modified Delphi approach to formulate some key recommendations for the use of machine learning in population health. Our first recommendation is really around prioritizing work to support communities historically disadvantaged by social and economic policies via things like paying closer attention to algorithmic bias mitigation and capacity building for representation advancement, including diverse collaborators with expertise in the realms of ethics concerning population health. In cases of public health emergencies like the pandemic, we advocate for the use of population-wide de-identified data, even without explicit consent, assuming the strong adherence to overarching ethical principles. Our third recommendation is two-pronged, but in essence, it's to assess harm in a manner that prioritizes the mitigation of potential algorithmic biases, especially those that are involving external or incompletely known entities, such as potential biases in clinical scoring systems that may have not been formally evaluated as of yet. Our fourth recommendation is to foster the collaboration between high and low and middle income countries and the adoption of ML-based data practices. Our fifth recommendation really revolves around the transparency around data sets, including providing details surrounding bias mitigation via the consideration of socio-demographic variables such as sex and race, and using appropriate handling strategies and advocating for things like open access data repositories to really foster this transparency around these data sets. Our final recommendation involves raising the public awareness about the benefits and potential harms and pitfalls of machine learning via making things more accessible to the public through the use of consistent, well-defined terminology, establishing reporting guidelines, and the use of plain language summaries. And I'm just going to pass back to Andrew to discuss how AI can support a learning public health system.
Thanks, Sharon. And so, we've taken you through kind of a general introduction and making sure people are familiar with these terms, some of the work that we've been doing, and then kind of what we learned from doing these 3 systematic reviews of the literature in this area. And I think one of the kind of key summaries of that is there's a real increase in application of these methods across a number of areas in public health, but very little still consideration of potential bias. And we're kind of at the stage where a lot of work is being done because it can be done, because we have data that people can apply these new methods to. And it's not necessarily where people are always considering the potential negative sides. The pandemic, of course, led to a huge increase in the use of these methods, specifically around COVID, and probably lots of you are familiar with some of that literature as well. But what we need to see is these methods being applied in a more transparent and ethical approach, and that's where the recommendations kind of touched on that. I think a lot of the recommendations that we came to were driven by what we learned in the evidence, but also there's a lot of consensus amongst people. These are all very kind of common sense approaches that will ultimately really strengthen the use of these methods in public health, and also really foster like a community that can use these methods and replicate each other's data as well. So what I want to turn to now in this kind of section before we actually move to general questions from everyone is how could these new methods in AI support a learning public health system? And this is bringing a bit of my experience over the last number of years with working to build primary care practice-based research networks, and starting to envision a national network of local and regional public health organizations in Canada. Part of, I think, what has led me to this is being part of communities like the Institute Advisory Board for CIHR's Institute for Population and Public Health, where really consistently we're seeing folks saying that we just don't have a really good data infrastructure in public health. We don't have deep enough investments to allow us to do comparisons and work together on evaluations and on research. We don't have, we have a lot of jurisdictional barriers to kind of collaboration. So this would in part kind of break down and say, this would be like a national network of groups. This also builds on, many people listening may be aware of the public health, research and education networks that existed in Ontario before funding cutback kind of led that system to come to an end. But there are kind of foundations that this could build on as well. So part of it is that in 2021, in the midpoint of the pandemic, the Canada's Chief Public Health Officer report, Theresa Tam, talked about a stronger public health research agenda. How do we accelerate knowledge translation and also rapid and ongoing population health intervention research? We were, in the midst of the pandemic, and a lot of organizations had to make decisions based off of limited evidence, or had to implement things without being able to evaluate whether it was working. For example, what is the most effective way to communicate to people about using masks or getting the vaccine? And, what are the best ways of actually running vaccination clinics? And while putting aside other important work, how do you make those decisions, and how do you evaluate the impact of having to scale back on, say, environmental health or chronic disease management while dealing with a communicable disease pandemic? The CIHR's Institute for Population and Public Health also looked at the top 10 opportunities for how we could strengthen our public health system, and called for context-specific research evidence and robust data. And this is something across our country is really linking research to practice. And so it becomes part of our workflow and not just something that's kind of completely apart from it. And so what are practice-based research networks? They're really living laboratories for discovery. They're where there can be, they're formed through a network of similar organizations. These can be practices, clinics, they could be schools, they could be any kind of entity, but they could also be like local public health units, where there is a joint work and cooperation to address pragmatic research questions. And they're really research questions that should emerge from the day-to-day work of the public health organization. There's a shared commitment to improving health through systematic inquiry, and I think this is shared by everyone here, is a really deep commitment to evidence-based practice. And there's some benefits to central coordination. So ultimately, every network requires some central coordination that helps with prioritizing questions, turning questions into proposals, getting through things like research ethics board applications, data sharing, and analysis. Having been involved with some of the local development research projects, I think there's examples where there are already good research that happens across public health units, funded by PHO, but often it's sometimes challenging to get projects up and running. One example is a relatively new network in Ontario that some may have heard of called Poplar. This is a primary care Ontario practice-based learning and research network. It consists of 7 primary care research networks, all of the 6 universities that have departments of family medicine, and then the Alliance for Healthier Communities collectively serves 1.8 million patients. It's funded predominantly through the Ministry of Health, and is linked to something called Inspire PHC. And what it does is it's one part of it is a provincial database of electronic medical record data, which is now getting constituted over in the next couple of months, and linkage to other types of data. The goal is ultimately for it to be updated nightly. And so there's this incredible rich information, and that it would expand over time. But the other part of Poplar is it's a network where questions come in, and very quickly it's decided, is this something that we should do? And, leads to also intervention research like clinical trials as well. And so a big part of this is being part of a learning health system where there is a continuous and very rapid approach to data that is generated through the actual work being brought together with the latest evidence, and then leading to practice change as well. And some of the key characteristics are having leaders committed to a culture of continuous learning and improvement, systematically gathering and applying that type of evidence, including to improve decisions, promoting the inclusion of community members. And many public health units have this as part of their work already, is engaging communities and helping set priorities, capturing and analyze data that is through the actual functions of the work, and then assessing outcomes as well. So what would a Canadian learning public health system look like? And what would be really the practical kind of steps to make it happen? It would likely require each participating public health organization having a research lead or someone who is the point person for this. There would be a need to streamline research approaches. Right now, many units have their own research ethics board approach, and often are trying to do that with limited resources. And Public Health Ontario also has its own REB system. So is there a way to make that harmonized in some way? A good example of that is actually in Ontario, we have something called Clinical Trials Ontario, or CTO, which actually has harmonized research ethics applications. So you just need to submit one to one center, and then it can actually lead to approval across multiple ones very rapidly. There's also a need, of course, to look at data sharing and even just construct clear data processes that capture the work of public health in a centralized way. Likely, this would include funding from provincial and federal levels, but also making it more easy to share research data between different entities, and also share funding more rapidly. There would, number 3, kind of establish a system to solicit and prioritize research questions, and then also support public health practitioners who develop an intervention that emerges from their work, and actually to test it as well. And then finally, supporting public health practitioners to be thoughtful and contributing site investigators on different types of intervention studies. One of the things, just bringing it back to kind of thinking about data, is to highlight this really important framework. Because if we think about the work of public health generates so much of information, so much data, whether it's on laboratory information, environmental health, vaccination and communicable disease data, and then also the work itself of public health. There's a really important aspect of actually engaging communities in having access to that data and making sense of it and helping direct it. We did see this during the pandemic, where many communities, once information about things like race was collected on who was getting COVID, it really led public health units to see there are these big disparities, and then actually work with communities on how do we narrow the gap. And so this is one framework from the Black Health Equity Working Group here in Ontario, which some of you may have come across. It's like a vision of community data governance, and I had the privilege of being involved with this group, but it goes through engagement, actual genuine ongoing consultation with community members, governance so that community decision-making happens about the collection, use, and analysis, including what sort of analysis and what are the concerns about things like machine learning applied to this. Access that communities themselves have the ability to access the data and determine who else can access it, and then protection as well. And what the goal is to prevent harms happening to communities when this data and when this type of work happens. And this type of framework, I think, helps reduce some of the harms that we talked about earlier when machine learning applications can happen without a lot of thought, and then it could lead to these types of biases that we talked about earlier. I should mention too that I know how challenging it would be for every public health unit to engage in this type of framework and actually do this work independently. So it's a great example where a collaborative approach at a provincial level probably would work a lot better. And colleagues at Ontario Health are already very much thinking about this, and it could likely kind of connect with that. One of the things just coming to COVID that we really saw is like very, very early in the pandemic, we did an analysis of data on just the first kind of 5 or 6 months of the social determinants of COVID. And really rapidly, we could see COVID was going to disproportionately affect racialized communities, certain types of workers who had to work and couldn't shelter in place, and then also folks who are lower income as well. And so we, along with others, advocated for the collection of data on race, and it informed things like the guidelines that the Canadian Institute for Health Information put out quite quickly. And it's a great example where we saw data being collected, identifying inequities, and then actually leading to investments at the municipal level and at the provincial level around trying to narrow these gaps as well. And many community health centers and other community organizations played a big role working with public health on outreach and actually narrowed these gaps. So this is kind of where we were in August 2020 in the city of Toronto, in terms of these very deep disparities that were really clear for many folks. And then, within essentially a year, you see a real narrowing, not complete elimination of the disparities, but quite a big reduction, probably very unique in Canadian history to see that kind of in a short period of time, a gap narrow. So I know that there are a lot of challenges to this type of thing happening, like the concept, like we don't do research within public health units. We're very much about delivering the services that are actually mandated by the standards that have to be followed, and there isn't the capacity and the resources around research. There could be lack of training in doing research as well, or lack of experience, or that units have had negative experiences as well. There could be a lack of dedicated time to actually do this. There's also a fear of helicopter research, where some researcher comes in, takes data, and then goes off with it, and there's no follow-up. There can also be, just the bureaucracy around ethics and data sharing agreements, contracts, and finances as well. So there's some solutions to this, I think. One is focusing on all of the public health units and organizations as spaces for innovation, and public health research as really, really relevant, and like actually creating the research that then guides the work. There, I think, can also be some, modest supports for people to pursue research training or ways to do this in a low cost but accessible way. There's the idea of also actually looking at people as they go into residency and more senior parts of their career, and identifying people who are interested in research. There can be dedicating grant funding, which is allowed by CIHR to actually dedicate it to people to be involved with research. And then there's also the importance of continually returning to sites, for example, once a year, to share what was learned, what were the answers, and to solicit questions as well. And then finally, there could be, this idea of that central support system as well for people. So just to kind of end our presentation and create time for questions, as we talked about, machine learning offers a lot of opportunities to look at key problems within public health, and also to address and mitigate inequities and biases that happen. But there's a need to really be careful in the consideration around how machine learning is designed, and some of the recommendations we talked about kind of brought that in right from the start. There's a need, of course, to adhere to equity, transparency, and engagement, which I think everybody here holds those principles, but it can be hard in practice sometimes when there's a bit of a temptation to just, you have the data, why not just develop and create the model? There's a need for continuous monitoring of outcomes to inform and to develop these guidelines. This is a continually evolving area, but proper use of machine learning can be a really powerful tool to promote fairness and equity as well. And there's a lot of potential. So we'll end there and really turn it to questions. And we gave ourselves a few more minutes for the questions section. So thanks everybody for listening.
And thank you, Andrew and Sharon, for your presentation. A lot of information to absorb there. We're now going to move on to the Q&A segment of this event to address some of the questions from our audience. Please continue to enter your questions into the Q&A pod if you have not already had an opportunity to do so. So we're going to start with a question about whether or not you can share the link to the guidelines you developed for the use of machine learning in public health.
Yeah, absolutely. We're actually just these are just being submitted for publication, but definitely we can share them. And also we're preparing like a lay summary that probably will be the most useful thing, like a one-page kind of summary of them for people, and really happy to share that with everyone.
Great, thank you. Another question, is data sharing and gathering easier when public health and practices or hospitals are in the same organization? And there's an example given of Saskatchewan Health Authority versus our system in Ontario with the multiple health units and hospitals.
Yeah, this is a really great question, and I have had some chance to work with colleagues in Saskatchewan and other jurisdictions. I think it's kind of both a yes and a no answer. One is it can be very overcome some of the hurdles around data sharing when it's within a single entity. I think actually Alberta Health Services, before the recent kind of policy changes that have basically broken up Alberta Health Services, is a good example in Canada of this, where you have a single entity and there is a lot of more ease in data sharing. But ultimately, it also comes down to what the people in politics can allow to, and what they're willing to allow. So Saskatchewan is a really interesting example where there's been a real reluctance to share certain types of data about the health system, and to establish entities that exist in other provinces. Like in Manitoba, there's a really fantastic Center for Health Policy that has for many, many years been a central place that's been very accessible and has allowed people to shine a light on government policy in a very objective way. Not every province has been open to that. So I think it really depends. I think there needs to be a continual push to say that sharing information and data is in the public good and in the public interest, and that it's really central to understanding how systems are performing, and also to be able to rapidly respond to emergencies. So we're at a time right now where we're emerging from the pandemic. we could see a lot of the challenges that happen with lack of rapid data collection and sharing. And we're just at the point where maybe there's a willingness and to revisit that. And I think a lot of the folks here, could play a role in that as well.
Great, thank you. So there have been a lot of discussions about capacity building within public health to start doing some of this work. What courses and programs would you recommend to prepare for an AI or machine learning career in public health?
Yeah, it's a great question. I'd be interested in sharing your thoughts as well on this. I think a few of the key things are, I think everybody in public health kind of requires like a general understanding of these methods, because they're quickly coming down the pipeline and will become integrated into our work in ways that we don't fully understand or can predict right now. And it could be everything from chatbots that triage public health inquiries to kind of automation of dealing with certain environmental data kind of that's being fed in a continuous way, to making sense of patterns, which using an unsupervised machine learning approach, to the analysis of social media feeds in an automated way using natural language processing or large language models. So it will affect many different parts. So everybody probably needs to have a general understanding. I think only a small number of people require the more advanced training in the actual methods and being able to work with them. But the good news with that is it's becoming more and more accessible. There are many, many actual free resources that people can pursue to dip their hands into working with these methods. There are fantastic free courses through MIT. And through many other sources. There are many introductions to using machine learning and NLP using R and Python, if people are in that space where they would like to acquire those tools. The University of Toronto, for example, runs a boot camp around machine learning to orient people to these methods very quickly. There's many courses that you could pay for as well and do training as well at a number of universities across Canada. So I think my own feeling is that I would definitely use the free kind of training that's available quite widely first, and really get a sense of it before you take on a potentially costly education. And the good news is because many of these things can be done with free software like R and Python, and also free data sets that are available widely. And there's tons of code and examples that are available. You can experiment on your own. The bigger thing is more, thinking about maybe what kind of questions you would want to answer and what's the use of the data, and actually doing that. I don't know if Sharon, if other thoughts come to mind for someone who's thinking about training in this area.
Yeah, I think it definitely, the career in AI and public health can definitely go in a lot of different directions, but I think it's important to note the two prongs where there is the technical piece, but also understanding the ethical implications and understanding the algorithmic bias pieces, to be cognizant when you're looking at those technical pieces of AI is important, rather than just focusing on one or the other.
Mm-hmm. Absolutely. I think it's a really, I was kind of hearing a presentation that was out of the UK recently, and they were making the point that while these technologies are going to disrupt multiple sectors, as Sharon mentioned, what's really valuable is actually also the human skills required to, there's, yes, working with the data itself, but the human skills of being able to work with people from different disciplines and bring people together. The ability to also provide that kind of ethical and social and political considerations of what the ramifications are is a very kind of unique area. And I think actually public health practitioners have a unique set of experiences in that because of the training and the work with communities. And also the ability to make things be able to communicate about ideas with different audiences and to explain what's happening in this black box to others is really valuable.
Okay, thank you. Good to hear it's not just about the coding.
Mm-hmm.
So one of our attendees is looking for the definition of data, and specifically, do you think there's any opportunity to include qualitative information within the work being done within machine learning? For example, needs assessments.
Mm-hmm. Yeah, it's a great question. And so the really neat thing is that although we often think of machine learning applied to numbers because essentially it's a way of extending traditional methods like regression analysis and going further, and often is based off of numbers like weighting of different kind of findings and training a model through changing those weights. It can be used to all sorts of different type of data. So actually many of the applications use things like natural language processing to process qualitative data. So I mentioned just briefly that idea of analyzing social media as a very common kind of application now. Large language models have just opened up this space enormously, and many folks here have probably experimented with ChatGPT or similar types of tools. So there's a lot of potential, and of course, there's a lot of potential around processing images, sound, and video recording and other types. So it's very flexible around that, really. I don't know if Sharon, anything you would add from some of the work? No, yeah. So it's basically, it can encompass many different types of data in terms of how it's processed and made sense of. Actually, a lot of the work using machine learning actually has been with visual images. For example, like being able to analyze radiographs or images of the retina or things like that and make sense of it.
Okay, thank you. So we have a long question here with a few parts. So given recommendation number 1, our attendee is wondering if you can speak more to how you would uphold principles of OCAP and Indigenous data sovereignty, other ethical guidelines around data collection, use, and reporting among BIPOC communities. So much of the data collected and reported on among Indigenous communities lack context, the considerations of lasting impacts of colonial colonization as they pertain to health data. How does AI capture these elements and help to report out data in a strengths-based way?
Yeah, it's a massive and really, really important area. And we were mentioning that there are real risks. In fact, probably most of the early examples of algorithmic bias have been specifically about how only after implementation then somebody evaluates how a machine learning model works and finds that it really performs differently for people of different racial background, for example. So I think that's one big area, is like now we've known for a number of years that these algorithms can basically encode bias, and we need to actually prevent that. And it's not just about more training data, it's actually about who's posing the questions and who's around the table, and also who's helping interpret, and yet everything from like labeling the data to making sense of the outputs. So that's one piece. I think the other piece is around OCAP and also other Indigenous data principles that have been created by Métis communities and Inuit communities as well, and the importance around sovereignty of the data and the connection to actually those principles actually about being these as individual nations, and that why part of it. That's why it's important to see those as particularly important and also distinct from community engagement in general, which is things like the EGAP framework that I presented, which are more for communities such as the Black community or the South Asian community or the East Asian community or the community of people living with disabilities or other communities, it's different because those are not sovereign nations, and so there's a different history and a different kind of legal relationship as well. So that's, I think, another aspect of it is the use and control of the data. And I think this is something that can be really not paid attention to. Like a good example that a colleague shared recently is around diabetes. There's an entity that simply wanted to bring together a massive database around people living with diabetes. And in particularly the prairie provinces, they were not paying attention to the fact that many people living with diabetes in the prairie provinces are Indigenous. And even though there wasn't a kind of a data point that said this person is Indigenous or not, you are still speaking about Indigenous communities. If you are looking at all the people with diabetes in a specific geographic area, you're going to be talking about Indigenous communities. I know many of the people here will understand that right away, being in public health, but it's where folks who are not in public health who then gain access to data may not think about that. And that's where the people here, joining us today have that understanding and that awareness of communities that you can bring into those discussions. So it's something I think really, it's about applying, good public health training and bringing into these discussions where sometimes people want to move really quickly and just say, well, just give me the data. I'll do some cool thing with it. And, that's not really appropriate. And that's why, as Sharon, went through the guidelines, a lot of it begins with kind of who's at the table, what's the question, who's this serving as well.
That's great. Now, I don't know if this is for Sharon, but we recognize the use of AI in research. We're just wondering if you've seen or have any examples of operational use of AI in, public health units or other areas of public health. Sharon, did you see anything in your lit search?
It's a good question. I think that for the most part, in population and public health, the greatest application is, modeling disease incidence and modeling like disease predictions. Like, it is to be noted that we like specifically didn't look at fields like occupational health and the more specialized units. But I think for the most part, predictive modeling is absolutely huge, and that's where we're going to see most of the uptick, or we have seen so far.
Great. Andrew, did you have anything to add?
Yeah, I think there were during the pandemic some great applications here in Ontario, and there's a very well developed kind of set of colleagues, particularly at University of Toronto as well as University of Waterloo, that have been applying these and kind of collaborating with public health units on some of these areas. So I think we're starting to see it already. And I think that's that we're already starting to see that as well.
Okay, great. So we have maybe 1 minute left. So the final question, as you know, public health units struggle with resource capacity to undertake research. What do you see as potential solutions or options for this barrier?
Yeah, I think it's a really key piece. I think a few thoughts are to strategically use the limited funding to build capacity, to also have public unit folks actually write and get grant funding to create kind of a virtuous cycle. Part of that can be a very practical thing is being able to obtain appointments at universities to allow you to apply and get these grants to then have it come into the unit. I think it's also like, saying if there's limited resources, what are maybe the key priorities and what can we do versus what can somebody else do? So there are, maybe other entities like Health Data Research Network or Canadian Institutes for Health Information or others who do a good job of bringing together data sets, they could play a role. And maybe it's more dedicating the resources to internal capacity building, and to ensuring there's that kind of training and that partnerships. I think one of the most interesting things would be is when you bring people together, what are the top questions, and then having that priority setting, which that type of priority setting exercise is not that expensive to do, but using that to then drive what grants are in and what funds are obtained.
Okay, sounds good. As we wrap up today's PHO rounds, I want to thank you again, Dr. Andrew Pinto and Sharon Birdie, for presenting. I also want to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. Also, a reminder to everyone that TOPIC, the Ontario Public Health Convention, will be held on March 26th and April 3rd in 2024. You can check out topic.ca for details. And lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you, everyone, and have a wonderful day.